Hi, everyone. I'm a developmental behavioral pediatrician and actually a division director here at University of Michigan. And if you haven't worked with a DBP before, we're trained as pediatricians, do a fellowship in developmental behavioral pediatrics, but the areas of interest and expertise can be pretty variable among us. Hopefully you'll have the opportunity to work with a DBP at some point. My training includes work with children in ADHD, elimination disorders, sleep disorders, which I'll have the opportunity to talk with you a little bit more about next week. But tonight we're going to talk about genetic disorders. So in this talk, I'll focus on neurodevelopmental disorders, but begin with a few basic genetic principles to remind you of terms that you might hear other team members use when they're referring to a patient's diagnosis. I'll then briefly review how to interpret standard scores with regard to IQ, as that's important to understand the profile of many of the conditions we'll review today. And lastly, we'll review the medical and behavioral manifestations of 4 genetic disorders as examples of how genetic conditions can affect individuals. At the very end are a few slides that give some references and resources for your review. And probably the most important thing to realize is that most of these genetic conditions have societies or associations that can provide you and families really helpful information and connect families to other families with these conditions. So as a quick review, and I'm sorry that that looks like the slide shifted, chromosomes carry genetic material from our parents, and normally there are 46 chromosomes that come as 23 pairs. The first 22 are called autosomal, and the 23rd pair is comprised of the sex chromosomes, which can be XX for female and XY for male. Genetic disorders are often described in terms of the chromosome that contains the gene, and if one of the 22 autosomes is involved, it's called an autosomal condition. Sickle cell disease is an example of a single gene autosomal disorder found on chromosome 11. Conditions affecting the X chromosome are called X-linked. Chromosomes contain genetic material and are usually found in the nucleus of the cell. The genetic material is DNA, and DNA contains bases, or the sequence codes for genes. The 4 bases making up the sequence code are cytosine, guanine, adenine, and thymine. DNA code makes up genes, and that is just transcribed to produce mRNA, which is then translated to make protein. Humans have about 35,000 genes altogether. Genetic disorders are also grouped by how they run in families. Some disorders are expressed as dominant and others as recessive. A dominant condition only needs 1 copy of a gene to be expressed. So in the first example, the first table shows a heterozygous condition, meaning that mother and father have both a large capital A for a particular gene and a small recessive A for that gene. So they have both alleles for that gene. In the dominant condition, which is the table to your left, capital A overrides any effect of small a. And so in the union of these parents, there is a 75% chance of having the capital A condition because it's expressed whenever capital A is present. If the condition of interest is recessive, and that is the second table, a condition is, this will show up only 25% of the time in offspring of parents who are heterozygous. The cartoon at the right-hand side of the slide shows an X-linked trait, and we'll come back to this when we talk about Fragile X. Here, the mother is the carrier of the condition on the X chromosome. She has a gene on, if she had the gene on both her X chromosomes, she would have the disease. But she is just a carrier. She has one normal X and one X that carries the gene. The 4 combinations from this union of a carrier mother and a normal father who has an X and a Y are as follows. So starting from the left-hand side, the normal male is the product of the mother's normal X with father's Y. The next one is mother's normal X with father's X, giving a normal female. The next is mother's abnormal X with father's Y, giving an affected male. And finally, mother's abnormal X with father's X, giving a carrier just like mother. Again, Fragile X is a condition that has this pattern of inheritance. So genetic disorder categories are as follows. The number of chromosomes may be in error due to a problem in the division process. So there may be too many chromosomes, 3 instead of 2, for instance, for Down syndrome, where chromosome 21 has 3 called a trisomy. Monosomy refers to having only one of a chromosome instead of both. And an example is Turner syndrome, where women have 1 X chromosome. A gene mutation results in a shift of the DNA sequence, which then affects the expression of the genetic code. Mutations can include a deletion or a gain, or a movement of the genetic material from one chromosome to another called translocation. As a result of such changes, there's a frame shift of the genetic code so that the proteins from the transcribed mRNA may be altered or not made at all. Other conditions might arise due to a change in how the genetic material is expressed. Such changes may occur through imprinting or methylation. Imprinting is the mechanism that underlies Prader-Willi syndrome that we'll discuss today. Epigenetics refers to the study of heritable traits or phenotypes that result from changes in the chromosome but without alterations in the DNA sequence. Methylation may cause a problem by marking a transcriptional or mRNA beginning point as on or off. A similar type process is histone modification. To determine whether a genetic condition is part of an individual's presentation, there are a number of ways that this occurs. Newborn screen is available in all states for phenylketonuria and congenital hypothyroidism, for instance. But Michigan tests for more than 50 disorders, including disorders of metabolism, hemoglobinopathies, endocrine disorders, and others like cystic fibrosis. One should consider a referral to a physician with training in genetics for a consultation, which would include a detailed history about the pregnancy, birth, development, and any medical concerns, but with particular attention to the family history for known genetic disorders, developmental disorders, or birth defects. Then a detailed history looks for physical clues of disorders, and further testing might confirm the diagnosis, which could include karyotyping, which determines the number and appearance of the chromosomes, a FISH or a fluorescence in situ hybridization, which detects the presence or absence of specific DNA sequences, DNA microarray, which uses hybridization probes to test for known DNA sequences, but those tests may miss unexpected gene changes. Biochemical genetics refers to the study of the amount or activity level of the resulting proteins of the genome. Okay, so now to have a, great.
That's what it looks like today.
So it's still a little bit off. Yeah. So a quick review of standard scores. I thought it would be helpful. Many disciplines use standard scores as it's a method to take an individual's performance and compare it to a normative population. This standard curve would be for an IQ score where the mean is 100 and the standard deviation is 15 points. Thus, the scores between 85 and 115 describe average performance overall for the population, which comprises 68% of that normal population. between 1 and 2 standard deviations on either end describes 28% more of the population, such that 2 standard deviations between standard scores of 70 and 130 describes 95% of the population. Individuals with intellectual disability are characterized by limitations in intellectual functioning and adaptive behavior. Comprehensive testing that's valid and culturally appropriate and measures that are more than 2 standard deviations below the population mean is a level of intellectual disability. So every standard deviation below 70 describes another level. Mild ID is 55 to 69, moderate 41 to 54, and severe below 40. So why might it be important to learn about neurodevelopmental disorders? There are many overlaps with autism, and many of these neurodevelopmental disorders have a genetic basis that carry with them affected systems, including medical issues, mental health, and behavioral issues. And in particular, some of the medical issues, knowing about them could be life-saving. Many genetic conditions also have predictable areas that are affected, and knowing about these allows earlier intervention and improving outcomes across various domains. Later in school, knowing about the pattern of educational needs may optimize educational planning, and knowing about genetic conditions can be important for family decisions and for family planning. So we'll talk for a minute about Down syndrome. This was first named or described, I should say, in 1866 by John Langdon Down. So just continuing with Down syndrome, it was first described in 1866, and in 1959, Dr. Lejeune in France discovered individuals with this condition that they had an extra chromosome. In the first half of the 20th century, most children with this condition were raised in institutions, placed there often soon after birth, which you heard about last week. The Mongoloid Development Council, though, was founded in 1961. It was called the Mongoloid Development Council because this condition was first called Mongolism. The association was founded by a mother of Kay McGee, a mother of Tricia McGee, Kay McGee, in Chicago, and Tricia is shown here. The McGees decided to take their baby home and started a support system for families of children who have special needs. This organization continues in Chicago as a Down syndrome society. And Down syndrome as a name became accepted in about 1970. Down syndrome is caused by an extra chromosome 21 and occurs sporadically. For about 95% of individuals, the extra material is from an extra chromosome. This is trisomy 21. This results from an error in cell division. In 3 to 4% of cases, there is a translocation of some chromosome 21 material. The material is attached to another chromosome, often to 14 or 21. And so these individuals have 2 normal chromosome 21s and extra 21 material. 1 to 2% of individuals have mosaicism, and this is where there is an extra chromosome in some cells, but normal number in others. Individuals with mosaicism may be more mildly affected. The diagnosis is usually indicated by physical signs in newborn age and confirmed with the FISH and karyotype tests for the majority. Down syndrome occurs in 1 in every 700 to 800 babies born in the U.S. and actually occurs across all ethnicities, races, and economic groups. The presence can be fairly reliably detected during first or second trimester screening. There is a risk at any age, but the risk increases with maternal age. At age 35, mothers have a risk of 1 in 250, and by age 48, the risk is 1 in 11. Here are some of the common physical features of individuals with Down syndrome. There are prominent epicanthal folds, that's the skin fold of the upper eyelid covering the inner or medial portion of the eye. There's an upslant to the palpebral fissure of the eye. Brush field spots, if you look closely at the picture of the eyes, are grayish or white spots on the periphery of the iris representing aggregation of connective tissue. There's a flat nasal bridge, small mouth, midface and ears, excessive skin at the nape of the neck, a single simian crease crossing the palm, and a short fifth finger that has an inward curve called clenidactyly. There are a number of medical problems that are common in individuals with Down syndrome. Numerous systems are affected, as shown here, and the percent occurrence is listed for some of them. Affected systems include sensory systems like eyes and ears. The heart and GI tract can have abnormalities that are congenital, meaning right from birth. Some issues like hypotonia are typically apparent early on, and others emerge with age. I'd like to highlight the hypotonia. This, along with smaller midface, mouth, and oral structure, together increases the risk for obstructive sleep apnea for these children. This is an example of knowing about the potential of a medical problem that can allow earlier intervention and avoidance of bigger consequences. Individuals with Down syndrome typically have IQs within the mild to moderate range of intellectual disability. This is true for individuals with trisomy 21 and translocation types, but individuals with mosaicism may have IQs that are 10 to 30% points higher, due again to that mix of normal cells and affected cells. Children have strengths in visual spatial skills, but weaknesses in speech and math areas apart from their overall IQ. About 50% of children and adults with Down syndrome have major mental health concerns. The most common include generalized anxiety, repetitive and obsessive compulsive behaviors, being oppositional, and having ADHD. Other problems can include depression and autism, and due to progressive changes with age, Alzheimer's is very common in older individuals with Down syndrome. So it may be helpful to think about when such medical and behavioral concerns might emerge for individuals with Down syndrome by age. An early clue, again, is hypotonia in the newborn period. This, in addition to physical features and feeding difficulties, might alert the team. Congenital heart problems might be identified on exam, but if Down syndrome is diagnosed, all infants have a consultation with a cardiologist. Anorectal abnormalities might be recognized and surgery might be needed and, again, life-saving. One might see that the early days for a family with an infant with this diagnosis could be very busy, overwhelming with worries, and fraught with many medical interventions. As infants, these conditions are still screened for by pediatricians and family doctors, and in addition, otitis is very common due to smaller ear structures. Anemia is also more prevalent than with other infants. Counseling early on about the risks for obstructive sleep apnea help parents to recognize signs and the team to intervene earlier. In addition to ongoing risks for otitis and obstructive sleep apnea, children are followed by ophthalmology for intervention for refractory errors and strabismus in efforts to help prevent amblyopia. Screening is important for instability of the cervical spine, particularly if there's neck pain or other change related to muscle tone, gait, or continence, and many are asked to avoid contact sports. Subluxation or a change in the vertebral column at the cervical spine occurs in about 15% of individuals with Down syndrome. Screening for hypothyroidism is done annually. Celiac disease is fairly common and is screened for if there are symptoms related to constipation or gluten intolerance. At younger ages, behavioral concerns may relate to limitations in language and communication skills, and many may see the pattern of ADHD emerge. These children can be inflexible, anxious, and present with deficits in social relatedness, again, for some raising the concern for autism. And again, for older individuals, there are higher risks for depression, anxiety, and over time, decline in cognitive skills. I'm just going to go back for a second. Individuals with Down syndrome live longer today. The lifespan was about 30 years in the 70s, and many live past age 60 today. There are an estimated 1.6 million children with Down syndrome worldwide. So we'll switch to Fragile X syndrome. This is the most common cause of inherited intellectual disability. About 15 to 20% of all intellectual disability cases are X-linked, and among those, Fragile X is the most common. This was the first X-linked pedigree of intellectual disability that was reported, and that occurred in 1949. The individuals Martin and Bell reported on turned out to have Fragile X when the testing became available in the 1990s. In 1969, researchers discovered a Fragile X site on X chromosome in association with two brothers presenting with developmental concerns and atypical features. The Fragile X mental retardation gene mutation was discovered in 1991. In Fragile X, there is a mutation of the FMR1 gene, which involves an expansion of more than 200 CGG, that's cytosine guanine guanine, repeats. CGG, again, refers to these bases. Individuals in the normal population have less than 40 CGG repeats. Individuals who are carriers for Fragile X, who have what's called a pre-mutation, have 55 to 200 CGG repeats. Pre-mutation individuals have an elevation of the FMR1 mRNA. The molecular basis for Fragile X syndrome is characterized by having a full mutation, which means greater than 200 CGG repeats, and methylation of the cytosine bases. This leads to a silencing of transcription and a deficiency or absence of the encoded protein, which is called Fragile X mental retardation protein, or FMRP. This protein regulates the translation of many mRNAs involved in synaptic plasticity. The absence or severe deficiency of FMRP almost always leads to intellectual deficits, as seen in males with Fragile X syndrome. In females with Fragile X, the normal X produces some FMRP, so only 25% of females with Fragile X have an IQ less than 70. Usually, expansions of the CGG repeats occur between generations when it's passed on by a female with a pre-mutation and becomes a full mutation in the offspring. So in the cartoon, the inheritance again is X-linked, and this is X-linked recessive. The mother is the carrier, and the son, having received the abnormal X from the mother and the Y from the father, is affected. Overall, the incidence is 1 in 4,000 to 7,000, with being about twice as common in boys. Currently, it's recommended to perform molecular genetic testing for this disorder in all children who have intellectual disability of unknown etiology. So I wanted also to mention Fragile X spectrum disorders, which really emphasize the continuity of clinical involvement for this condition. So this really describes the pre-mutation problems that were first recognized for females who had early menopause, and this occurred in female carriers. This is known as Fragile X-associated primary ovarian insufficiency, and about 20% of female carriers have this condition. The next pre-mutation disorder identified was Fragile X-associated tremor ataxia syndrome, seen initially in older male carriers greater than 50 years of age. This involves intention tremor, altered gait and having ataxia, and is a neurocognitive disorder that occurs in about 40% of men and 16% of women with the premutation. The point to knowing about Fragile X spectrum disorders is that if you're aware of other affected family members, that might give you a clue about whether the child you are caring for might benefit from Fragile X testing. Individuals have a variety of neurologic, cognitive, and behavioral deficits with Fragile X. Males with the full mutation and full methylation have little or no FMR1 mRNA and little or no FMR protein. The physical presentation and dysmorphology include signs of connective tissue disorders. This includes a long, narrow face, large, prominent ears, larger forehead. Many have a large head called macrocephaly, and they have a prominent jaw. Their palates are high-arched, and their finger joints hyperextensible. They have some hypotonia, or low muscle tone, and they have flat feet. Their skin is soft. Their chests often have a sort of an inward dent kind of into the sternum called pectus excavatum. They often present with scoliosis and mitral valve prolapse. Other features include large testes after puberty, and about 24% of males and 6% of females have seizures, and those with seizures are more likely to have autism. About 30% of young children with Fragile X may not have obvious dysmorphic features, and the features may be even more subtle in younger children, increasing the importance of screening for this disorder if intellectual disability is present. Intellectual disability affects about 85% of males and 25% of females with Fragile X. The average IQ for a male with a full mutation is 40, or low moderate ID. Females with Fragile X often present with learning disability or borderline intellectual functioning. The level of FMR protein correlates directly with IQ. The main area of academic underachievement is in math. Other commonly affected learning domains include short-term memory and working memory, executive function, and verbal deficits. About 30 to 60% of males with a full mutation meet criteria for autism spectrum disorder. However, the most prevalent mental health concern is ADHD, affecting about 80% of males and 30% of females. Many also have sleep problems, including insomnia and variable sleep maintenance and total sleep times. They are more likely to have stereotypical behavior, poor eye contact, even without autism, and sensory sensitivities. Treatment for the ADHD with traditional psychostimulants or SSRIs for their anxiety may be helpful, but newer treatments are being studied at this time, particularly for the behavioral dysregulation that can accompany Fragile X. Individuals with the full mutation have a normal lifespan and thus need support throughout life. Turning now to Prader-Willi syndrome, this was also described by John Langdon Down, but in 1887, and he described an adolescent girl with mental impairment, short stature, hypogonadism, and obesity. It wasn't until 1956 that Prader, Willi, and Labhart reported on a series of patients with a similar phenotype. And in 1981, Ledbetter identified deletions on chromosome 15 that was determined to be the site for Prader-Willi syndrome. This is primarily a microdeletion syndrome, where there's an absence of paternally, that means father's inherited genes, on chromosome 15. This was the first identified imprinting disorder. In imprinting disorders, the gene expression depends on the parent the gene is derived from. Under normal conditions, the maternally derived copy of chromosome 15 is inactivated or methylated in the region critical for Prader-Willi syndrome, and the unmethylated paternally derived region is expressed. 70% of the time, Prader-Willi syndrome occurs when there is a lack of expression or an absence of the paternally inherited gene. And this occurs, again, on chromosome 15 between bands 11 and 13. Prader-Willi occurs for the remainder from a uniparental disomy. This occurs about 25% of the time when there are two inactive maternal copies of chromosome 15. The prevalence of this disorder is 1 in 10,000 to 30,000 individuals. As infants, individuals with Prader-Willi syndrome present with a narrow face, almond-shaped eyes, a small mouth, and a thin upper lip. They have downturned corners of the mouth and small hands and feet. As infants, they have central hypotonia, decreased movement, and decreased arousal, a weak cry, weak or absent reflexes, and a poor suck. In fact, most infants with Prader-Willi syndrome require tube feeding due to failure to thrive in infancy, which is really an irony when it comes to their later behavior. Feeding problems typically resolve by 18 to 24 months, and then appetite increases, and into the preschool years, food-seeking behavior emerges. Weight increases, but not muscle mass, and the hypotonia remains. Children with this condition have a lower metabolic rate, altered thermoregulation, and without treatment, a high risk for obesity and short stature. Children are also at risk for scoliosis, osteoporosis, and problems with lower extremity alignment. Sleep problems are very common. With the hypotonia, overweight, and narrow facial structures, the rates of sleep-disordered breathing are very common. Intellectual dysfunction for individuals with Prader-Willi varies from moderate impairment to normal IQ with learning disabilities. However, for a majority, they're in a borderline to mild intellectual disability range. Whatever the IQ, learning disabilities are common. They are generally friendly individuals who really want to please and are more likely to get upset if they think that they've disappointed you. They have generally good verbal skills, and although they can have some expressive articulation problems, and they have a particularly unique, excellent ability with jigsaw puzzles. Early on, they may have delays in motor development, which is present in 90 to 100% of individuals, and achieve motor milestones at about double the normal age. Physical therapy is really important as an intervention in this early period. Language is also typically delayed. Behaviorally, 70 to 90% of children in the preschool years have temper tantrums, are stubborn and controlling, and can be inflexible, particularly if routines are changed. They are egocentric, and it's hard for them to take another person's perspective. Autism is a consideration for individuals with Prader-Willi at about twice the general population rate. ADHD and insistence on sameness are common, but do improve with age. Psychoses can occur in young adulthood for about 10 to 20% of individuals. Skin picking is common at fingers and at anus, and many have poor short-term memory, problem with math, and difficulty achieving independent activities of daily living. Treatment with growth hormone improves outcomes for many. And this really now begins in infancy and has really revolutionized the care for individuals with Prader-Willi. Body fat and BMI decline, as shown in the picture of the boys 2 months and 13 months on growth hormone treatment. Since growth hormone treatment can increase tonsillar size, however, it's important to consult with a sleep specialist and obtain a sleep study before and on treatment to make sure that obstructive sleep apnea doesn't emerge with treatment. Behavioral intervention is very important for medical and behavioral concerns, and people describe 3 important rules for individuals with Prader-Willi that really help settle down their anxiety and improve their their compliance. That is, no hope, no doubt, and no disappointment. And as it relates to food, that would be no hope of food between meals, no doubt that the food will come on time, and no disappointment that it will always arrive. In addition, many families need to really lock down refrigerators and cupboards to secure those rules. I have to say, though, that those 3 rules are true for other behavioral interactions with children with Prader-Willi syndrome.
Barbara, you have a question?
Okay.
Coming from Wayne, does growth hormone treatment need to be continued throughout life or just through adolescence?
I think I may have to verify my answer here next week when I come back to you, but in clinic we use it really up through the pubertal growth spurt. Does that answer the question? Okay.
Yes, I think so.
Okay. So going on and ending with Rett syndrome, this was discovered and named after Dr. Andreas Rett, who first described a series of patients in 1966. This is in association with the MECP2 gene that was discovered in 1999. This is also an X-linked dominant, an X-linked condition, but it's dominant, and it involves mutations in this methyl CpG binding protein 2 gene. This gene almost always occurs on the maternal X chromosome. It occurs almost exclusively in girls, but if it occurs in males, it's much more severe and progressive with death by 3 years of age. This area of the X chromosome encodes an epigenetic regulator that's highly expressed in the nervous system. The prevalence of this disorder is 1 in 10,000 to 15,000 females and occurs in all racial groups. This is a progressive neurodevelopmental disorder, but not a degenerative disorder. Patients with this syndrome exhibit reductions in gross brain volume over time, but that's associated with the presence of abnormally small, densely packed neurons with reduced dendritic complexity and synaptic density. The course and severity is determined by the location, type, and severity of the mutation. The course typically involves 3 stages: pre-regression, regression, and post-regression. The course is not a steady deterioration, but periods of stability and then progression in between. So in pre-regression, children have a normal appearance in infancy up to about 6 to 18 months. However, early signs can include hypotonia and motor delays. One may see abnormalities of general and fine finger movements. Other early findings can include a lack of social smile, an expressionless face, an aloof, indifferent demeanor, lack of eye contact. As infants, children with this condition are often described as really good babies who sleep for long periods of time. By the 2nd year of life, there is a loss of acquired language, ambulation is delayed, and there is social withdrawal. Children have dysregulation of breathing with breath holding and hyperventilation, and sleep disturbances. Purposeful hand movements are lost between 12 and 18 months, and characteristic hand movements develop, like ringing, clasping, clapping, hand-to-mouth tapping. We might also see SIB, which is self-injurious behavior, like hand biting and hair pulling. Children exhibit impaired balance, poor strength, tone, and locomotion. They may have hypertonicity developing in the legs by early childhood. Seizures increase in incidence with age and affect most individuals with Rett syndrome by age 10 years. Later in childhood to early adulthood, there's a relative stabilization. Intellectual disability is present, but their communication can improve, although primarily through eye gaze. Seizures may improve. Although motor areas slowly decline, There can be joint contractures, rigidity, and scoliosis. It is really by adulthood that most will lose the ability to walk. Individuals with this disorder can have sudden, unexplained death by their fourth decade. Therapies for Rett syndrome are developing, and pharmacological therapies are targeting neurotransmitter disruptions, growth in cell metabolism factors, and gene therapy. The life expectancy is into their late 30s for 60%. So I hope you'll take away from these conditions how complex medical, developmental, and behavioral issues can occur, and how important it is to work in alliance with the child's medical team and medical home. So though there will be other formats within the LEND curriculum to discuss adult transition, but before finishing, I'd just like to mention that children with neurodevelopmental disorders are eligible for educational support in all states up to age 21, and beyond in many up to age 26, like here in Michigan. Once out of the school system, each state provides an array of support for the adults with disabilities based on eligibility, need, and the wait list for services. In Michigan, 1.9 million of 10 million residents have a disability. That's about 1 in 5. The Michigan Alliance for Families offers education and support, and Michigan.gov also has a website for disability resources. So I have listed for you some websites and papers that I hope you'll find helpful to find out more about these conditions in particular. But again, other genetic conditions have much in the way of web resources through their societies and associations. Thank you.